Hello, welcome back students. So, in the previous class we were discussing about pharmacodynamics, right, and today we are dealing with again pharmacodynamics, the rest of pharmacodynamics. So far we have discussed what is pharmacodynamics, what are the principles of pharmacodynamics or principles of drug action, the mechanisms of how the drug acts in the body at the receptor level or at the biomolecular level, at the place or at the site where the drug is acting, or how these impulses or drugs are acting, we have discussed. Now, we were discussing about that, and the mechanisms already we have discussed about the ion channels, the receptor, different types of receptors, how the receptor, the impulse is transduced and all. So, I have just briefed all. So, the receptor transducer mechanisms will be discussed later, a separate class is there. Okay. It is a very important topic for you. So, we will be discussing that receptor transducer mechanism long in separate another class, but for making an idea of pharmacodynamics we have to know what is receptor or receptor, that was already discussed. Okay, the few points. Then again different methods like mechanisms like enzymes we have already seen. So, today we will be discussing the later part of pharmacodynamics. Okay. So, in the previous class I have told that the drug can act on anywhere, right, some ions or some receptors or even enzymes, and there are some drugs they do not have any specific site for action, but they causes some actions. And in our body there are different types of enzymes which catalyzes many biological activities or many physiological activities. So, there are some drugs which will be inhibiting that enzyme. So, that will be specific for that reaction in the body. Acetyl for examples we can say that enzyme and the inhibitors. So, the drug or the enzyme acetylcholinesterase which will be inhibited by physostigmine. Then angiotensin converting enzymes will be inhibited by drugs like captopril, which is used as antihypertensive drugs. Carbonic anhydrase inhibited by acetazolamide, used as our diuretics. Cyclooxygenase, which is an enzyme or which is the principal pathway which is seen in our pain mechanisms and all. So, it will be inhibited by aspirin. Then DHRF, again in the folic acid metabolism and all, the drug methotrexate. HMG-CoA reductase, simvastatin. So, the statin drugs which are acting on our cholesterol pathway and all. Xanthine oxidase, again in our mechanism or in the metabolism of our proteins, inhibited by allopyranol. So, there are so many enzymes in our body which will be inhibited by some different types of or different groups of drugs. So, these enzymes are specific and the drugs are also specific, right. Okay. I hope you understand that the different biological or physiological activities in our body is to take forward by some enzymes or catalyzed by many of the enzymes which I have already displayed here. So, these they will be specific for that action. So, the drugs acting on that also will have a specific activity on that enzyme. Okay. Next group of drugs or next principle or mechanism of action is by inhibiting the transport proteins. So, in the initial class of absorption, the pharmacokinetics, when we are discussing, I have told about some transporters. They will transport some mechanism, some substance from one place to another. There are different type of transporters are there, which some transporters need energy, some transporters need some movement of ions, some transporters need their difference in the potential or the ionic differences make them transporters. So, there are so many transporters which are proteins or there are different types of transporters in the body. So, these transporters also can be modified by our drugs. So, the carrier mediated transporter proteins are inhibited by different types. Choline uptake. So, this is a transporter seen in our acetylcholine metabolism. So, or in our autonomic nervous system, these all are mainly seen in our these the classes of these the classes which involve these type of enzymes or proteins or carriers will be coming in later classes, and also you should have some idea about these, what is this receptors, or what is these transporters, and also like that. The choline uptake, so this is a different specific transporter which uptakes the choline in our what we will say the neuronal junctions, and also they can be inhibited by hemicholinum. It is a drug. Monoamine uptake, tricyclic antidepressants or SSRIs. So, these are adrenergic uptake system. Adrenergic system, we can see this monoamine uptake. The transporters, they will transport the, or will helps to move the adrenaline or noradrenaline in the neural ends. So, they can be inhibited by tricyclic antidepressants or SSRI, selective serotonin receptor inhibitors. Okay. Another group of drugs, H plus K plus, or it is known as the proton pump, which is in our stomach and all. It can be inhibited by the omeprazole. Another Na plus K plus chloride, Symport system. Again, the furosemide, which is acting, which is mainly seen in our kidney or in the nephrons. It can be inhibited by the drugs like furosemide, which acts as an antidiuretic drugs. So, not only the receptors or ions, there are some other places also where the drugs are acting. So, I want to make clear that not only the ions or the ion channels or the receptors, the drug can activity on some other areas in the body also. So, these all are biomolecular level where the drugs are acting. So, the ions are there, receptors are there, enzymes are there. Now, the transporters are there. Okay. Again, there are areas. See here. Here it is non-receptor mediated drug actions. So, in the initial or the previous class I have told that the drugs may be acting some sort of places, or even there is no such place for action or specific place for action. So, like that here the physical activity of the drug, okay, the physical or the physique of the drug itself is acting as a or has a mechanism. Here the bulk laxatives like agar. So, when there is a constipation and all, the patients will be having constipations. So, these types of drugs, they itself will act as some laxative. So, they will form a bulk forming laxatives like agar. Osmotic purgatives, again this is the same concept, magnesium sulfate and mannitols. Then adsorptions, charcoal. Charcoal, you know that when there is a poisoning or something like that, when we give charcoal, activated charcoal, the physical activity of the charcoal will absorb or adsorb the chemicals which are seen or which are dangerous to our body. Demulcents, glycerin, astringents, tannic acid. So, these all are their physical activity itself is having some drug action. Okay. So, they are not directly acting anywhere in the body, but their physical activity itself has got some action. Now, the chemical activities. So, chemical means there will be some neutralization or some chelation. Okay. So, the neutralization of gastric acid by our antacids. So, this is a chemical activity. Antacids which be having the the potassium or sodium salts, their chemical activity will neutralizes our HCl produced in our gastric mucosa. Okay. Then the chelating agents, again in heavy metal poisoning and all, we will have to give some thing which will absorb or chelate that metal activity. They are chelating agents. Then the physiochemical activity, alcohol, even alcohol is dangerous, but alcohol has got some medicinal values. We know that in our sanitizers, which are very commonly using nowadays, its physical activity and it has got some chemical activities also for the killing the organisms. So, they are not directly acting in the body or directly acting on any other micromolecular level in the body, but they have got some medicinal activity. Okay. So, these all are the different methods or different areas or different mechanisms of actions, how the drug act in the body. Okay. Now, we will move to another part of another important part of our pharmacodynamics. I have told the pharmacokinetics means what the body does on the drug, and pharmacokinetics means what the drug does to the body. So, if something is done by the drug, there should be a response, or it is known as the response. So, the mechanism or the final effect of a drug action is known as the response. So, we have a relation between our drug and the response. Okay, there is a relation between the drug and the response. and when we combine this drug and response, when we tabulate or when we calculate the effects, it is represented as drug response curve, or we will, when we plot this dose and the drug dose and the response on a graph, we will get an graph, we will get an idea. So, this is known as the drug response curve or DRC. So, this is the graph showing dose response relation. So, there is a relation between the dose and the response, okay, and the graph is known as dose response curve. Here the dose is plotted on x axis and the response is plotted on y axis. Okay, you will be knowing in your max classes and all, we have studied that if you draw a graph, there will be a x axis and the y axis. The x axis and the y axis. So, in the x axis we will denote the dose, and in the y axis we will denote the response. Okay. So, we can plot this graph, or we can get this graph by giving values of the dose and also the calculating the response. Okay. If you extrapolate this into a graph, we will get a this sheet, we will get a graph. So, this is known as dose response curve. So, there are two types of dose response curve. One is graded or simple dose response curve. Here we take the actual value of dose which we have given. If you say we are given 10 milligram, then 100 milligram or 1000 milligram, we will take that 10, 100, 1000 or 1, 2, 3, 4, 5, 6. So, it is a simple graph starting from the 0 or 1, and the response will be given same way 1, 2, 3, 4 it will be given. But another type of dose response curve, here it is known as log dose response curve or log DRC. Here we will take the log value of our doses and the response in the normal way. So, for the advantage of this dose response curve, the important advantages of the dose response curve is that we can extrapolate, we can calculate a huge amount of doses or a large quantity of doses. You know that log values are much more lesser when compared to the normal values. Okay. So, in DRC the dose the log response curve, the dose is converted to logarithmic scale and is plotted. So, as I have told, the dose will be like 10, 100, okay, or the dose will be in log value. So, 1, 2 means 1 and the 2 means it will be denoting the 100. Okay. So, we can get a large, we can plot a large values. That is the main advantages of log response curve. And the DRC, the log DRC is more convenient and it is the commonly used dose response curve. See here, here we are comparing two types of doses, or sorry, two types of DRCs. Here the drug concentration or the doses and the response is given in the percentage. So, when we are taking a simple dose response curve, so we are giving a simple doses 1, 2, 3, 4, 5 here, and the response is in the percentage. So, we will be get a hyperbola. See the graph will be like a hyperbola. As we know, when we increases the dose, the response also will increases. So, some places or some region, the response will become a maximum region. So, when we increase the dose, there will be no further increase of response. Okay. Maximal response will be reached. So, it is in the simple dose curve. So, when we are taking a log response curve, here the initial part will be slow sliding and which will increases. When the dose or the dose is within 30% to 70%, we will get a steep increase in the graph and a region or the place where it become a maximum response. So, further increasing of the dose, there will be no difference in the response, maximum response. So, but we are getting a linear line here between a 30 to 75% of doses, we are getting a linear line. So, this is a very important region, and again the dose response curve, the important part of dose response curve also will be discussed later separately as an important class. So, we will get a linear line here. So, this is very helpful for comparing different drugs or different doses. Okay. So, this is the main difference between the dose response curve and simple dose response curve and log response curve, log dose response curve. Okay. Now, there are some disadvantages for the simple dose response curve. They are large variations in the dose cannot be plotted on a simple graph paper. As I have told, when we are taking 1, 2, 3, 4, 5, 6, if we have got a dose of 1 and 100, so the area or the x axis will be prolonged. The x axis we will have to make so many papers to get a 100. Okay. Then comparison between two drugs response is also not possible. So, the hyperbola will be somewhere in other places, and it is very difficult to get a comparison. Okay. And the main advantage of the log response curve, other one simple response curve. Now, the advantage of log response curve, being a logarithmic scale, less space only is required for plotting. A large variation of the dose can be plotted in a single graph paper itself. As I have told, even when the log 10 and log 100 is 1 and 2. So, between 1 and 2 we have getting between 100 doses. So, we can plot in a small space, we can plot a large variation of dose. Comparison between two drugs is also possible. The dose response is also possible with the log response curve. Now, the uses of DRC to compare the efficacy and potency of the drug. So, when we are comparing the efficacy and potency of a drug, we can use dose response curve, mainly the log dose response curve, to distinguish between the competitive and non-competitive antagonism of drugs. We will be discussing each part, what is efficacy, what is potency, what is antagonism, and all we will be discussing. And for calculating the therapeutic index and safety margins of the drugs. Okay, so these all we will be discussing. So, this is the main use of our dose response curve. One is to find the efficacy and potency, other one to find the antagonism, type of antagonism, and find the therapeutic index and the safety margins of these drugs. Okay. So, what is efficacy and potency of a drug? When we think in a layman's language, both are same, efficacy and potency, but there is some technical difference between that drug. Efficacy is the maximum effect produced by a drug. It is the maximum effect produced by a drug. So, the maximum height of DRC shows the efficacy. Clinically, the efficacy is more important. So, efficacy means the maximum effect produced by a drug. Okay. There is no importance for the dose here. You can see in the definitions there is no dose coming. Only the effect produced, maximum effect produced by a drug is known as the efficacy, and the maximum height of the dose response curve. So, the dose response curve, when I have told the dose response curve, when we increases the dose, it gradually increases and reaches a maximum. A point it becomes maximum, and further increase of dose cannot make any difference in the response. That point is known as, or that the maximum peak of, or the maximum height of the DRC is known as the efficacy. Okay. So, clinically this efficacy is more important. Now, what is potency? Potency is the amount of drug required to produce the response. Okay. It is the amount of drug or amount of drug required to produce the response. So, if it is not the mere response, it is the desirable response. So, we want a response or we want a action, and there are different types of drugs. So, the drug which produces that response in minimum amount, or the minimust amount of drug which produces the desirable response is known as its potency. So, a drug which having a small amount or in small amount can produce high response or a maximum response, then that drug is maximum potent, or it is having the highest potency. In case of less potent drugs, the DRC shift right, that I will discuss later, or that I will show later. Okay, what is happening in that DRC? The steeper slopes of DRT indicate marked decrease or marked increase in response with a slight increase in the dose. Okay. That also we will be showing in the graph. See here, this is a graph showing a dose response curve, log dose, here log 1, log 10, log 100 is there. Okay. So, here you can see two colors, x and z. They have got the, consider here it is the maximum, or this point is the maximum response. Consider this is the maximum response region. So, these two x and y have reached this maximum point. So, they are efficacious. So, they are efficacious. Okay. So, they are efficacious. So, this is our maximum response, and they are efficacious, but the y has not reached this point or this its line. So, it is not efficacious when compared to x and y. Okay. So, that is the efficacy. Now, what is potency? Here you can see x and y, the two graphs of two drugs, one is x and y. Here it is the dose is between 0 and log 1 and it produces a response, or maximal response which we want. But the dose of z is in between log 1 and log 10. Okay. Here it is 1, here it is 10 and it is starting in between the 1 and 10. So, the dose is between the log 1 and 10, the other one is between 0 and 1. So, which one will be having less amount? Obviously, the x will be having the drug x will be having less amount. So, the less amount itself has produced a maximum response or a desirable response. So, the x is more potent. Okay. So, when we see when we look into this figure itself, we can understand what is efficacy and what is potency. Here the x and z is equally efficacious when compared to y, but when we compare the potency out of x, y, z, x has got a maximum potency. Okay. Here you can see the potency of comparison of morphine and pethidine. The morphine. So, consider this line, or here is the area of maximum response, or the denotes the maximum response. So, the morphine at 10 milligram itself has produced this much response, and the same response for pethidine, for the same response we need 100 microgram. So, comparing that, which is more potent? The one which has lower amount, it is the morphine. 10 milligram itself has produced this maximum response, that is. So, morphine is more potent. Okay. Now, antagonisms, in competitive antagonisms, that we will be discussing later. I will be showing that later. Again, non-competitive antagonisms, again that I will be showing. Now, next important use of our DRC is to find out the therapeutic index or safety of a drug. We before administering to a patient or before giving the drugs to a patient, we have to know the safety of that drug. Okay. So, there comes the importance of our DRC. So, what is therapeutic index? The gap between therapeutic effect DRC and adverse effect DRC defines the safety margin or therapeutic index. So, the gap between this safety is the gap between the therapeutic effect and the gap between the adverse effect DRC. So, when we have to plot a graph of therapeutic effect and also plot a graph of adverse effect. So, in between that, the area between that space or the gap between that two DRCs is known as the safety margin or therapeutic index. So, it can be calculated by taking a ratio between lethal dose 50 and effective dose 50. Okay. LD 50 by ED 50. So, LD 50 means the lethal 50 percentage. Lethal dose 50% means the 50 percentage of the dose at which 50 percentage of patients has got adverse effect, that is the lethal dose, lethal 50. Then ED 50 means the effective dose 50, that means the dose at which 50 percentage of patients got the effective region. Okay. So, the therapeutic index is calculated by median lethal dose divided by median effective dose, is LD 50 by ED 50. So, the lethal dose by effective dose. So, when the index is high means, or it is more than 1 means, the drug is more safe. Okay. The therapeutic index should be more than 1, it indicates the safety of drug. So, the effective dose should be more than 50. ED 50 should be more. Okay. And greater the therapeutic index, more will be the safety of drugs, I told. Okay. Mean effective dose means the 50% of test population showing therapeutic effect. I have already told that. Median effective dose means the 50% of test population showing effective therapeutic effect, and the median lethal dose means 50% of test population showing lethal effect. So, an adverse effect. Okay. The drugs with wide therapeutic index like diazepam, penicillin. So, they are very safe to use in patients, and the drugs with having narrow therapeutic index are digoxin, lithium, phenytoin and theophylline. So, these all drugs, the effective graph, the dose showing the effectiveness of this drug, and also the dose showing the graph showing the lethal effect of this drug are very close. So, there the space or the gap between these two DRCs are very small, and that means there is a high chance for toxicity. So, when we increase the dose or when we increase the amount of the drug, it can leads to toxicity. Okay, that is the importance. So, these all we have to find this whole thing before we are administering a drug, and it is obtained by our comparing the dose response curve. So, this is the main importance of the dose response curve. Okay, see this two separate graph. One is therapeutic effect and the other dose is toxic effect. So, where the 50%. So, this is a log graph, and when we take the 50% of people, 50 individual, the effectiveness is compared in 50% of people, and this is ED50. So, the region where the 50% of the population is effective is known as ED50. The dose required to produce therapeutic effect in 50% of population. And the same way TD20 or LD toxic effect, ED 50 means the dose required to produce toxic effect in 50% of population. Okay. So, when we combine this graph, the graph therapeutic effect and the toxic effect. So, there is 50% therapeutic effect and 50% toxic level. So, the gap between this ED50 and LD50 is known as the therapeutic index. So, the graph between the LD50 and the ED50 toxic effect or lethal effect. Okay, between the this and this is known as the therapeutic index, safety margin. Okay. Here you can see the dose response curve of analgesic and depressant effect of morphine. So, even the morphine is an analgesic drug, it has got some depressant action. So, the important effect we need is analgesia. So, when we give or when we take the graph of 50% of people having analgesia, this is the response, not the 50%, the people having response is the blue graph, and the pink graph or the violet graph is showing when the dose is moved to higher dose, which causes depression. So, you can see the dose is started from low dose, and here even the started from the middle area. So, it has gone to toxic effect or the depressant effect. So, this area, this graph or the gap between the safety margin, the analgesic effect and the depressant effect is known as the margin of safety, or the dose range we can find out from this graph. So, this is the importance of our DRC. Now, what is therapeutic range? It is the dose range of drugs bounded by the dose which produce minimal therapeutic effect and the dose which produce maximum acceptable adverse effect, and also it is also known as therapeutic window. Therapeutic range and therapeutic window are somewhat similar. One is it is the dose range of drugs produced by the dose which produces minimal therapeutic effect and the dose which produces the maximum acceptable adverse effect. So, the adverse effects we can consider that the acceptable adverse effect. So, which has not produced any lethal effect, but it is adverse, and the minimum therapeutic effect. So, the graph between that is known as the therapeutic range or therapeutic window. Therapeutic index is something different. Okay, you have to understand the difference between therapeutic index and therapeutic range here. Range is somewhat bigger than therapeutic index. Okay. Here you can see we are taking a graph of therapeutic effect and the graph of acceptable adverse effect. Here the doses, the initial doses or the dose where it started to produce a therapeutic effect, the minimal therapeutic effect, and it gradually increased or it reached a maximum level. Same way we are taking the adverse effects or toxic effects. It has started here and we are taking about a 50%. 50% of people where we the maximum acceptable therapeutic or adverse effect. Adverse effect is not something that acceptable, but for a mathematical or for a phenomenal effect we are considering or we are taking that area as a minimal acceptable adverse effect, and consider it as a 50% or 50 lethal 50. Okay. The rest we have list, and this graph, this area is considered as the therapeutic window. So, therapeutic index and therapeutic window is something different. Okay, therapeutic index and therapeutic window is different. I have to make it clear that both are different. Now we will move to the Now we will move to the last part, that is the combined effect of drugs. It can be a positive effect or negative effect. So, positive effect by combining two drugs is known as synergism, and the negative effect or the stopping effect is known as antagonism. And in synergism itself we have got two types. One is additive synergism and other one is supraadditive synergism. Okay, and in antagonism there are different or four types of antagonisms. One is physical antagonism, chemical antagonism, physiological antagonism, and receptor level antagonism. So, each we will be discussing. So, this is a situation when two drugs are combined. Okay, again effect, what happened to the effect of drugs. So, the initial part I have told the use of DRC, we have to find out the efficacy and potency, then the antagonisms and the effects. Okay, so antagonism I will discuss here. So, additive synergism. So, synergism means a positive effect. That is known as synergism, and in synergism we have got two types. One is additive and one is supraadditive. What is additive synergism? If the total effect of the drug is equal to the sum of their individual effect, it is called as additive effect. So, it is like a simple addition of two effects, effect of drug A and effect of drug B is equal to, or when we combine this A and B, the effect will be same. So, like in max, 2 plus 2 is equal to 4. 2 plus 2 is equal to 4. Here when we combine paracetamol and aspirin, both has got analgesic effect. Theophylline and ephedrine for bronchial asthma, and also the individual actions are adding and getting the total of that individual action. So, it is known as additive synergism. The next one is supra-additive synergism. So, it is something different than additive synergism. Supra-additive, if the added up effect is greater than sum of their individual effects. So, a drug A and drug B has individual effect, and when we combine this drug A and B, the effect is more when calculate the total or the sum of their individual effect. That is known as supra-additive effect. So, the effect of drug is 2 and the effect of drug is other drug is 2, and we combine them and we get a, naturally we have to get 4, but here it is more than 4, the effect received is more than 4, then it is known as supra-additive synergism, mainly seen in different combinations like levodopa and carbidopa, which is used in Parkinsonism. Levodopa has got some effect individually, carbidopa also has got effect individually, but we combine the effect or combine these both two drugs, the total effect we received is when it is more than the individual effects. Okay, so that is known as supra-additive synergism. Now, antagonisms we have got four types of antagonisms. First one is physical antagonism. So, it is a negative part of combining two drugs. Physical antagonism, the effect of one drug is inhibited by the physical property of that another drug. So, if there is a drug A and B, we are combining, the effect of drug A is stopped or inhibited by the physical activity of drug B. Okay. For example, charcoal. In the initial part, I have told what the charcoal is doing. Charcoal is an adsorptive agent, so it will adsorb some substances. So, when in poisonings and all, when this charcoal is activated, charcoal is given, the surface of that charcoal will be absorbed, or the surface will adsorb the chemicals on their surface, and it is useful in alkaloid poisoning. So, this is the physical antagonism, physical property of a drug which inhibit the action of another drug. Okay. Next is the chemical antagonism. Again, the chemical thing I have already told, what the neutralization of the drugs and all. Here the two drugs interacted chemically and one drug neutralizes the effect of another one. So, when there is a drug A and when there is a drug B, when we are combining the drug A, the effect is decreased by drug B due to its chemical activity. So, same way in antacids, and which neutralizes the gastric acids. In our body, in our gastric mucosa, the HCl is produced. So, when we are giving antacids, it will inhibit the action of antacid or inhibit the action of our gastric secretions by chemical activity. Again, the calcium EDTA in lead poisoning and all, they are forming some complexes and the effect is reduced by its chemical activity. That is the chemical antagonism.
Third one is physiological antagonism, or also known as functional antagonism. Here two drugs act on different receptors or different sites, but their pharmacological effect are opposing each other functionally. Okay, so the drugs, the two drugs A and B is there. A has got some effect on some different space or different receptor or different site. B is also having different receptor and different site, but their actions are opposing. Okay, that is known as physiological or functional antagonism. For example, histamine. Histamine act on H1 receptors and produces bronchospasm. So it causes bronchospasm in the lung. But adrenaline, it is the effect is on beta 2 receptors. Adrenaline has got action on beta 2 adrenaline or salbutamol or anything. They has got action on beta 2. It is different from H1 or histamine receptors, but they produces bronchodilation. So even though they are acting on different sites or different receptors, the action, the final action of each is opposing. One is causing bronchospasm and the other one is causing bronchodilation. Okay. The same way, our insulin, which reduces the sugar, and the glucagon increases the sugar, blood sugar. Both are acting on different sites or different region, and the action, the final action is opposing. So this is known as functional or physiological antagonism. Next is receptor level antagonism. Receptor level antagonism, there are three types mainly. Okay, receptor level antagonism, there are three types. First one is competitive antagonism or reversible antagonism. Competitive or reversible antagonism. Here the both agonist and antagonist drug compete for the same receptor. So there is a receptor is there and drug A and drug B is there. The drugs, drug A and drug B is competing for the same receptor. The agonist and antagonist drug is competing for the same receptor. Okay. In the figure you can see here a figure. In this figure, this is considered this is a receptor, and there is some space for attachment of these agonist and antagonist. So this is the agonist. So when the agonist is attached to the receptor, the action will occur. But the same way, the antagonist, the competitive antagonist or the reversible antagonist is also competing for the same receptor and is attaching first before the agonist. So when the antagonist receptor is blocked by this antagonist, the agonist cannot block or cannot attach to the receptor, and there is no response antagonism of agonist. Okay. So the antagonistic effect is a completely reversible. So but the antagonistic effect is completely reversible. When we increase the agonist, the amount of agonist, or when we decrease the competitive or antagonistic level, this response will be reversible. Okay. For example, morphine and naloxone, they both are acting on opioid receptor. One is the morphine is agonist and naloxone is antagonist, pure antagonist. Same way the adrenaline and prazosin, they have acting on alpha receptors, but one is agonist and the other one is antagonist. Okay, so the competitive antagonist, they will be the agonist and the antagonist, they will be acting, both will be acting on the same receptor. Okay. Now, see here. This is the graph showing a competitive antagonism, agonist and antagonist. In the same way, when in the initial part for the drug response curve. So here we are taking considering, or this is the graph showing agonist alone. Here the graph showing only agonist. So this is the ED50, effective dose ED50, and this is the dose. You can see this is the dose, and the efficacy is also reached here. But when we are adding an antagonist with the agonist and agonist, again gradually when we increases the dose of agonist, we have reached the efficacy, nor the initial efficacy of antagonist alone. So here the dose range has increased. Okay, the concentration of the agonist has increased. That means it has reduced the potency of agonist. Okay. So in the initial part I have told, when the dose is increased, it will increases the the potency will be increased. Potency means the minimum amount to produce a desirable response. So here when we add antagonist and agonist, we have to increase the dose of agonist to reach a desirable effect or reach the maximum effect. That means we have increased the dose of agonist. That means the potency of the agonist is reduced. Okay. Now the competitive antagonism, non-competitive antagonism. Competitive antagonism we have told what is it. Next is second is non-competitive antagonism. Here the antagonist is chemically unrelated to agonist. Though the antagonist and agonist are different. And it binds to different allosteric site, altering the receptor in such a way that it is unable to combine with the agonist. See here in the picture. So consider this is a receptor. And there is a area for attachment of our agonist, and also there is another site called allosteric site. Allosteric site, the drugs or the antagonist will be binding to this allosteric site. So our antagonist has the structure of antagonist is something different than the agonist, but the competitive antagonism, the structure of agonist and antagonist was similar, and the antagonist will attach to the site of agonist itself. But here the antagonist will be attaching on the allosteric side, some sites other than the agonistic site, but it makes a conformational change in the receptor, and our agonist cannot bind to the receptor. So again the response is not produced, but the agonist is not binding. In the initial thing, the competitive antagonism, when we increase the agonist level, it can reverse, but here the high agonistic concentration is unable to reverse the block completely. That means they are binding to some other place. So even when the receptor is changed or the receptor morphology is changed, our agonist cannot bind there. And even though we increase the dose of agonist, we can't make any change, or we can't reverse the competition between the agonist and antagonist, because they both are attaching on different sites. Okay. For example, diazepam and becuclin, they are having different sites. And the graph here. So this is the graph showing, the black graph is showing, or DRC is the graph of our antagonist alone. So this is showing a response. And when we increases the dose of antagonist, non-competitive antagonist, the graph is becoming, or graph is flattening, reducing the height. The height is the efficacy. In the initial part I have told, the height of the graph shows the efficacy. When we adding more and more non-competitive antagonists, the graph is becoming flattening. So reducing the efficacy. That means it decreases the efficacy. The competitive antagonism will decreases the potency of the drug. Same way non-competitive antagonism decreases the efficacy of a drug. Okay. Now I think you are more, you have got more idea about the graph. Okay. One, the competitive antagonism will decreases the potency. Same way the non-competitive antagonism will decreases the efficacy of the drug. Okay. And the third one, it is known as non-equilibrium antagonism. Non-equilibrium antagonism. It is something different from competitive and non-competitive antagonism. It is non-equilibrium antagonism. Certain antagonist binds to the receptor with the strong bonds, covalent bonds, or dissociate from it slowly due to very high affinity. So some drugs have a very high affinity towards some drugs, or some antagonistic drugs have got high affinity towards some drugs than the agonist. So when they are attached to the receptors, they will be dissociated very slowly. Or some way some antagonist drugs will have a strong bond with some drugs like covalent bond. Here also the dissociation will be slow. So the agonist molecules are unable to reduce the effector occupancy of the antagonist molecule, and it is known as an irreversible or non-equilibrium antagonism. It is the irreversible or a non-equilibrium antagonism. For example, phenoxybenzoamine is a non-equilibrium antagonist of adrenaline at the alpha adrenergic receptor. So in the later classes we will be more, we will have got a more idea of this phenoxybenzoamine and alpha adrenergic receptors. So when we are discussing the autonomic nervous system, we will be getting more idea. So this is something different from competitive and non-competitive antagonism. Here they are making some covalent bond between the receptor and the antagonist, or when they are having a high affinity, the dissociation will be slow. That's why they are causing some irreversible or non-equilibrium antagonism. Okay. So finally we have finished our pharmacodynamic part. As a summary, we have discussed about pharmacodynamics in 2 classes. What is pharmacodynamics, what is the principles, and how the mechanisms and actions of drugs. Okay, the principles of pharmacodynamics I have already discussed. The mechanism of drug actions like ion channel receptors, enzymes, then the chemical activity or physical activity, or the drugs which have got no receptors or enzymes for their action, but they are producing actions. And also I have mentioned about the dose response curve, what are the uses of dose response curve, like efficacy, potency, the competitiveness and all. We have already seen what happened with the dose response curve, and also antagonisms, what is antagonism and different types of antagonism, and also about the synergisms, also additive synergism and superadditive synergisms. So all these are important for you. You have to study these things thoroughly, then only you will be then only the pharmacology part become easy for you. So you have to study the basics first, and I strongly recommend you should read the textbook along with these presentations, then only it will be more helpful for you. And I think we can stop here today's class. So study these topics. Thank you. Stay home, stay safe. Let's break the chain. Thank you.